So welcome to another episode of School Airway. Today we're going to talk about my latest version of gastric diversion and use of the supernova. I have an 80-plus-year-old female who found to be mute based on a card talking about she needs sign language for translation in her purse, and somehow she's a pet struck. Found by herself with no family and friends to talk about her medical history. Patient already admitted to the SICU. She's about to go up, but has episodes of hypotension because we had found out that she had pelvic fractures that were with maybe a possible blush, but more likely having venous bleeding, not arterial bleeding. She already got a central line. She hasn't been intubated yet. Right before she goes up, the attending upstairs asked me, can I intubate this patient for them? But instead of me deciding who intubates or I intubating the patient myself, the patient gets intubated, or the person picked for the initial attempt at intubation is a junior, PGY2, in a different department. But that attending, who was also in the room, wanted me to supervise her intubation. So, play nice. It's not Game of Thrones, not that violent. So, decided to supervise. Or has an IV connected to a monitor, suction is ready. This resident, this trainee decided to use a DO blade despite the fact that she's Asian. At least in my experience, in my 11 years, Asian patients, usually there's a subset that has a very anterior airway, regardless of how normal their external appearance looks. Either a prominent tongue compared to their small mouth, or a small mouth, and just the design of their airway is slightly more anterior than usual. Alright, so my other resident who was right next to this resident was going to use a glide scope if she failed. It's an assumption that people have full stomachs. We're going to minimize bagging because she's spontaneously breathing. She was getting a high flow oxygen through a face mask. But I decided to upgrade this method to something what I think is more superior, which is like a supernova. Because I'm also preparing for failure in case this novice fails. Alright, so I disconnect the oxygen from the port of the high flow face mask, connect it to the supernova device. Now I'm going to attach this device to her. Alright, now this looks like a foreign object to a lot of people because it's a relatively new product, but hopefully it won't be like that in the future. Alright, so I'm trying to package her up, getting her have a tight seal. Alright, so this doesn't fall off, and so she can oxygenate. Okay, and I may have to loosen this up on one side. It's not aligned correctly. Alright, even it out. Alright, okay. Connect by BVM. Alright, attach PEEP to it, which is already on. Make a tight fit on top. This is also connected to a high flow, more than 15 liters. Alright, and the trainee already has prepared her suction catheter. She decides to intubate with a DO blade. This whole time, sats are 100. Alright, and I hope it stays that way with the supernova. It's always been explained to the trainee that this device will stay on while they're intubating. So I'm going to show you what happens. So medicine gets given, decisions made for etomidate, and then it sucks. Her labs had come back, no renal failure, no hyperkalemia noted, and also to ensure neurosurgery can reassess the patient constantly with a relatively short-acting polarizing agent of sucks when it wears off. Not ROC or VEC, though it was recommended by me, but they wanted sucks. So, the patient fasciculates, and I'll show you what happens. Alright, so we disengage the mouthpiece. Alright. She goes to intubate. Does not lead with the suction catheter. Does not. Alright. And what happens next is she goes in and the patient starts pouring out emesis everywhere, flooding, almost like a salad demonstration by James Ducanto. Flooding everywhere. Patient had the seat collar on, even though the CAT scans were negative, and we wind up having to assist her in being turned. So we have to disengage, pour out the oxygen, pour out the vomit to the side. Unfortunately, I was to the right, and two surgical residents turn her onto her right and vomit all over my shirt, my pants. And then we assume that the vomiting stops. Alright, she goes back to suctioning because she can't see anything. Alright, she goes in, she suctions for 2 seconds, and it's clogged. There's a little bit of panic in the room. We disconnect that Yankower and put another one in. And guess what happens again? She goes in, she tries to oxygenate, and then guess what? She can't see anything. The SAT's still in the hundreds. This device is working. The Supernova is working and oxygenating her, despite all this emesis coming out. All right. So the decision has to be made that the trainer does not know what she's seeing, and made a decision to upgrade an intubating person to my PGY3, who I know, who I've trained, or I had to decide myself if I'm going to intubate the patient. All right. So in the time that he's deciding to move and change over to the glide scope, patient continues to throw up. So I made the bold decision to do this. Open the jaw, blind the goose the patient. The attending who had chosen the other trainer is asking, "What are you doing?" I told them I'm inducing something called gastric diversion to prevent more vomiting. Vomiting is pouring out to the side, starts to slow down, push it over to the left. Alright. So I allow enough time to happen, allow enough vomit to come out, that when my resident who has already gotten the glide scope enter the airway, he can continually suction. He knows that more vomit, if it's coming out the esophagus, can be poured out, diverted away from the trachea, from the glottic opening, and the tube went in. Alright? Now, in all this action, the SATs eventually went down. Alright? So there was probably a lag of when the oxygenation really got cut off because of all the vomiting going on. Still kept this on. Alright? Right? Vomit had shot out through their nose. Alright? All we had to do is just disengage it. Before, I made sure I just cleaned it out, decanted it like how decanter would decant things, I guess, and used it again, and our SATs went back up. Alright? I confirmed placement after my resident got it in because I saw it visualized through the monitor connected to the glide scope Cobalt. I knew it was in, put end-tidal CO2, confirmed it was in. We suctioned through the tube. After the intubation, some material came out and the SATs went up. Now, this is one way of doing gastric diversion. That's a MacGyver method, but so much stuff was coming out, I had no choices to put it in. I do not have a big stick. I only have these Yankowers. They're optimal for patients who have been fasting and only have clear liquid and gas in their belly. Not for lentil soup or corn chowder that has debris in it that easily clogs these small holes. Okay? Alright, so I was able to do this. I was also able to try to snake over this tube, which was an 8.0, because more stuff was coming out. Flip the end over, This is an inspiration from John Pester, another doctor who I learned from on Twitter. And as more stuff was coming out, just connected it to the wall suction, and that prevented more emesis to happen. Alright? MacGyver maneuvers are needed to prevent worsening injury and to ensure patient safety. Alright? Please come back for another lesson of School of Airway.